Great. Well, thank you everyone again for coming to the January 2025 WAG Journal Club. We are so excited to have Dr. Forray come to present for us today and her title of her presentation today will be Patient and Provider Perspectives on Child Protective Services and Perinatal Opioid Use Disorder, Lessons from the Support Model for Addiction-Related Treatment, or the SMART trial. And we have her bio here, and I will put it in the chat. But what I'm going to do is hand things over to Dr. Forray and get things started. Please, throughout the presentation today, please put your questions in the chat, and then we will be monitoring the chat. And then we do have dedicated time for Q&A at the end of the presentation today, and we would love to have a discussion going forward. So Dr. Forray, you're welcome to take it over.
All right. So, and everyone see my slides? Perfect. Thank you so much. Excellent. So I can still got my slides, and then I can still see you all, which is always helpful. So I'm really excited to be here today. Amongst, I feel like it's like my people, right? Sort of like the work that we do is not easy, and there's a lot of challenges, but it's always nice to know that there's a community of like-minded folks that are doing this important work. So for me, it's just an honor to kind of be amongst all of you. A little bit about me. I am reproductive psychiatrist, and essentially have built a lot of my work around caring for pregnant and postpartum individuals with substance use disorder. And so that's sort of always been my passion, in addition to just reproductive psychiatry in general. I'm an associate professor of psychiatry at Yale, where I also serve as the section chief for our psychological medicine service, which is all of our consult-liaison services and integrated clinics throughout Yale New Haven. And also happen to be the Yale Director for the Access Mental Health for Moms. It's for those of you that don't know, the perinatal access programs. Connecticut has one, and I happen to be able to help run that, which is really exciting. And we just need to have more of those programs across the country, and more of them that support not just mental health conditions, but also substance use, which I think is really, really important. So with that, that's a little bit about me, and really sort of getting to what what I wanted to present on today, which is really some of the work from our SMART trial. And let me tell you more about that. So back in 2018, we got funding from PCORI. It was a very specific ask. They were looking for ways to compare models to support obstetric clinicians providing treatment for opiate use disorder to pregnant individuals. And so that's sort of what we responded to and got this grant. And I have to put this disclaimer up before I move further, that PCORI has nothing to do with what I'm about to say, other than funding the study that we got the data from. This probably for you all is just more a review of like the impact nationally on opiate use disorder, and how it also not only increased in the population in general, but the perinatal population as well, so that I can move through that. And I think specifically one of the things, and this is just one specific example of the fact that, there these rates of use and misuse of prescription opiates as well increase, yet and while there is a need for treatment and engaging these individuals in treatment, very few, only 32 got reported being kind of counseled on receiving treatment during pregnancy. So again, it's an important sort of, and I think this is probably what instigated sort of PCORI really wanting to fund this, right? So we have this big problem, yet very few people are actually getting access. And a lot of them actually want to do the right thing, right? As 99% of the patients I've ever cared for, right? They want to do the right thing in pregnancy, yet they aren't finding treatment. And so that was really the impetus for this work, right? And again, this kind of brings that home, right? So despite the obstetric care providers, are caring for patients, all patients and patients with opiate use disorder during pregnancy, very few are actually providing medication treatment. And even within the treatment programs for opiate use disorder, a lot of them don't feel comfortable treating pregnant individuals. So again, it really brings this idea of like, can obstetric providers be a place where patients can get treatment during pregnancy? And then thinking about some of the barriers, right, as we were thinking about the approach to this study, for patients and barriers for providers, right? A lot of it is sort of availability of services, right, which we already touched on a little bit, accessibility, affordability, and then acceptability are key core components for patients. And then for providers, feeling like they lack experience, time, resources, support from their institutions, et cetera. And obviously a lot of concerns around, there's concerns about like, well, I don't know, what do I do with a pregnant patient with an opiate use disorder? And then concerns about the mandated reporting aspects, but also there's a lot of stigma still, unfortunately, within the healthcare system and with providers. And really, this is part of what we were hoping to tackle with this. So as I mentioned, sort of there really is a need to be able to think about building capacity, right, for treatment for opiate use disorder in the perinatal period. And, reproductive health settings are, kind of, in my opinion, one of the best places to do that. Um, Yet, one of the things is that while we have models for non-pregnant populations that have been established as good models to help, build capacity, we don't necessarily have that for perinatal populations, and that's really where PCORI came in and stepped in with this funding announcement. And really, what they wanted to look at is what is the comparative effectiveness of different strategies for providing support or coordinating services for, and this is old language, so medication assisted treatment, but now we all call it MOUD, or medication treatment for opioid use disorder, to providers who offer office-based treatment for pregnant individuals. Um, and so that's exactly how this project came about, really trying to compare two models. And so the models that we were comparing were collaborative care, and it's sort of a version of the Massachusetts OBOT model, which is a slight variation of the traditional collaborative care, versus Project Echo that most of you might be familiar with, and which is sort of a virtual learning community with like monthly webinars and kind of having access to experts and being able to discuss cases on a monthly basis. And our main outcomes were engagement and retention in treatment between the two groups, and then we did a whole host of patient related outcomes. And we did this across 12 sites in Connecticut and Massachusetts. And it was split even between, six perinatal settings in each state. It was a diversity of settings. We had some that were in urban areas, some that were in suburban areas, like a handful in sort of more rural areas, as rural as Connecticut and Massachusetts can get. But and then a variety of sort of, we have some FCHQs and some academic medical centers as well as private practices. A little bit on the collaborative care model that we implemented. So patients were screened for an opiate use disorder and other substance use by a care manager identified in the clinic. This was usually a clinic nurse. In some sites, it was the social worker, if they had one in the clinic. And then patients were enrolled into a registry, and then the case managers helped the physicians or the obstetric providers in assessments, discussing treatment initiation and follow-ups. And then, they did provide education, and we did train them in sort of some recovery coaching as well, and help with care coordination. So that was sort of the model. There was, unlike the traditional collaborative care model, there wasn't a psychiatrist or addiction specialist in this model. It was just really the care manager, the patient, and the physician. So that's the variation, and that's following the Massachusetts OBOT model. And then for the Project Echo version, similar to other echoes, um, we had these monthly meetings where we had providers from across the sites that were randomized into Echo meet, and we'd have didactic presentations for the first half, and then have case discussions subsequently. And again, most of what we made were recommendations about what they should do. They didn't need to do a registry. They didn't need to do universal screening like the collaborative care model did. But we just sort of provided a lot of information, and then it was up to each individual clinic and program to decide what to do. And we did do some work around sort of implementation of the echo model, et cetera. But really what I'm here to talk about, so this is just to give you an overview. So this was the project. And then at some point I'd love to come back and talk to you about what we actually found. We're in the middle of doing the data analysis. We just completed, we wrapped up our final data collection in November. And so we're in the middle of looking at the data and see what the outcomes are. But as part of this, one of the things we found out early on, and as we're thinking about like what are the barriers to being, for obstetricians to be able to provide this care in the clinics, but also for patients. One of the things we kept hearing kept coming up was this idea of mandated reporting and child protected services. And so what we asked Corey to do is, could we do some qualitative interviews to take a look at what was happening and get a better sense. So what we did is we had one representative, patient representative, at least one from each of the clinical sites that we did key informant interviews with, and we did them over Zoom. And then we had one obstetrician, nurse practitioner, or social worker, any of these folks in any of the models as part of the study, also participate and do these interviews. And it was really, really illuminating. We've already published on the provider perspectives, and I have the paper listed later, and we're just working and trying to finalize the patient perspectives, which is so valuable. And so that's what I'm going to be sharing today, is really what we found in terms of the themes from both of this, asking both patients and providers, or participants and providers, about this. So these were some of the areas, and I won't read through them because we'll really kind of go through them as I read you some of the quotes. This was just really powerful. So but the main thing, not surprisingly, that we found repeatedly and pretty much universally across these interviews with patients is the fear of having child protective services involved, right? They were afraid of getting in trouble. They were afraid of actually being open and forthcoming about what was happening, because they didn't want to be treated differently, because they didn't know what was going to happen. They didn't know whether, disclosing what they were going through, or that they were still struggling maybe with use, or et cetera, would lead for them getting child protective services called, and then what would that mean? And this one quote is, the whole pregnancy I was scared because I didn't know what was going to happen. The fact that my son got adopted, and this is from a prior pregnancy, and I didn't know what the outcome of this baby was. It was very scary. And again, that this is a theme that came up a lot. And I think one of the things to think about is that a lot of times these participants, had already experienced a lot of trauma. I mean, we know that that we know that a lot of times trauma and substance use disorders go hand in hand, and there's added trauma, right, from these experiences of having prior interactions with child protective services, losing custody of a child, even if they do manage to get it back, right? The whole thing is very stressful. And this is, I think, something that kept coming up. And I think something that's really important for us to be aware of, right? How traumatizing this can be. To the point, right? This is the last quote, like really, and this was not the only participant that mentioned considering termination as an option because of the fear, right? So it was, my kids getting taken away. I was going to, because of CPS, I was going to get an abortion just so my other kids would not be in harm's way or have a chance of taken away. So again, the other component to this too that I think is in here is the idea that once you are, if you're pregnant, right, that is a window of opportunity for potentially having child protective services called on you, and that referral made, which then can open the window of, like, it potentially puts the other children at risk too, right? So once an investigation is opened, and I think this was particularly salient for our participants in Massachusetts, which luckily this has now changed, and too bad Tabitha's not here because she can speak on the fact that Massachusetts finally changed its law. But when we did the study in Massachusetts, a pregnant individual getting MOUD in pregnancy it was mandated that they had to have a report to child protective services, right? So again, this becomes a huge barrier, as we'll see, for getting care. They have since changed that, just I think a month ago it got written into law that they're changing that. But again, this becomes a big barrier. The communication came up again, both with participants and providers, as we'll see. But again, this one first quote for me was really telling. That this patient had essentially gone in, had an emergency C-section, got put under anesthesia. And then when she woke up, all of a sudden she was told that Child Protective Services was notified and that she would be losing custody of her infant. So like think about like this idea of like just, going through a C-section, going into delivery, very and in the midst of that, then finding out that this is happening, right? And the fact that there was no communication prior, and this sort of came out of nowhere, right? And I think that's another thing that kept coming up. The doctor's letting you know that they're going to call CPS, when they're going to call, why they're going to call, like all of this, they say it would be really important. So like really brings home the point of the idea of, knowing kind of what the policies and the laws are at your state, and how your hospital, for example, implements these laws is really important for providers to know, so they can actually clearly communicate this to patients, particularly early on in the pregnancy, and not come as a surprise, as they're delivering. And I really like this last quote, put it in direct language, not in switchy words, right? Like, and I think this is so true. Like, we forget how a lot of times we say things in which we want to couch it. We don't like, and I think a lot of times it comes from a good place, but we end up using maybe jargon or saying things in a way to kind of hedge our bets, and the patients see right through that, right? It's like none of this, no switchy words, not complicated words that can be interpreted different ways, right? Just plain simple language. And I think that really having that honest conversation in plain simple language can go a long, long way. And then, of course, this to me is one of the more concerning. I mean, all of these are, but this in particular is the concerns about automatic reporting for postpartum individuals undergoing medication treatment for OUD, right? And again, luckily this has changed in Massachusetts. This was never luckily the case in Connecticut. But I know in a lot of other states it's not, right? And this really becomes a big barrier. So I'm going to maybe just focus on, I never want to get pregnant on methadone ever again. I'm not going to go through that again, not being terrified for all 9 months and my baby's going to be taken away, simply because they're doing the right thing, simply because they're following evidence-based treatment, right? And recommendations. And so again, I think this to me was really, really important. And an opportunity, right, to really use as an example of like being on medication. Evidence-based treatment should not be a reason why child protective services should be involved. And then obviously, not surprising, bias and stigmatization were very, very high on these participants' minds. And so one of the quotes was just really feeling like they were viewed differently because they have a substance use disorder, and that we were treated differently, and that there's automatically this sort of doubt, like this, like, you're going, that they felt the providers and other folks in the healthcare system were approaching them, already assuming the worst, right? Assuming that they're going to have to call Child Protective Services. And a lot of times feeling that they're just basing it on like, oh, you happen to be, have a history of opioid use disorder, or happen to, endorse use or be on medication, that's the single thing they're basing it on, and not really fully understanding everything the patient is dealing with and potentially struggling with. And we know that a lot of our patients are struggling with multiple, social determinants of health, right? And so, that's why I really, really like this quote about they don't know the situation. They don't know what led you there. They don't know what's going on at home. They don't know anything. And they're just sort of making this report based on this one piece of information, which again, really, not explicitly in here, but kind of goes back to this idea of like, which is, I think, a whole topic for another day, about, the role or lack of a role for urine toxicology testing, right? And again, why we should be moving away from that, because frequently that's the one piece of evidence that gets used to justify making these referrals to Child Protective Services. Yeah, and so this idea they need to dig a little deeper and really understand what's going on. So and the other theme that really came about is really how the idea, and this again goes with the stigma and fear that we already discussed, but how it really impacts their well-being, right? And so this one participant reported, I ate, slept, and was breathed thinking about CPS the entire time. It was bad. Reflecting back, literally all I talked about Child Protective Services. So then it becomes like this whole fixation that like that's all they're worried about, instead of really like, you know, their pregnancy and all these other things, getting ready for the baby's arrival, things like that. They're just worried about like what's going to happen, like I'm going to get reported, and what's going to happen when Child Protection Services gets involved. Um, and one of the things that, this one participant mentioned is that maybe between the hormones and the fear, it all just accumulates into CPS is bad, right? So that they think that ends up taking a lot of, again, mental space and negative space, and particularly when they're pregnant, because they're afraid of everything, and I think that this creates a certain sense of vulnerability, that there is like a target on their back. I think is one patient quote said it at some point. And so, again, kind of also touching on the fear. And it was really depressing and drove me further into addiction. So for some folks, like this is a stressor, and we know that stressors can be triggers. And so it's extremely depressing, especially when you are taking care of your child day in, day out, and then your child is ripped out of your home suddenly. It's disgustingly depressing, right? So this really kind of brings that home. So, and then there is some silver lining in this, and I think, and thinking about this, that there are times where Child Protective Services can have a positive impact. And I think what came through both from the patients and the providers is that's when you have a caseworker that's actually working to support the patient, right? And kind of utilizing this report to Child Protective Services as an opportunity to support rather than as a punitive measure, right? And as a punitive intervention, as so frequently it's perceived and so frequently is operationalized. So if you do get a good worker, they do work with you. They really do help with staying on top. They get you into programs. They do more than they have more pull than a young person trying to get help on their own. So they recognize that there is some advantage of having someone really when they're wanting to help them, right? Which is really the spirit in which this should happen, right? And trying to help have the best outcome and help in the recovery of the patient. So when they do referrals for children, for in-home therapy, outside therapy, earlier intervention, they can also help financially, so that there is this sense of like when again it is meant to be supportive and help them be in the best position possible to care for their infant, then it actually can be a positive thing. And then again, this one worker for this one patient really advocated for the patient and being able to get their son back, and really allow them to be engaged and work towards reunification. Um, okay, so now we're going to switch a little bit, and hopefully I'm doing okay on time, and move on to awesome the clinician perspective. And this again, we already published last year in the Journal of Women's Health. And again, we'll just kind of go through the themes again. So it's like touching on the while limited, clinicians did feel that there could be some positive effects of Child Protective Services. And again, particularly when it's a caseworker that's going to be really working to support the pregnant and postpartum individual, and really helping them connected to childcare, housing, etc. Right. So really that again highlights that how key having support around those, basic needs are, and are really an important piece of treatment and recovery. There were a lot of concerns about mandated reporting affecting prenatal care. And again, this is consistent with what the literature has shown, but really this is, really telling to see how a patient didn't show up for care, right? Because Child Protective Services told them that they were going to take the baby away, right? Or that's how at least the patient had interpreted a conversation with Child Protective Services. And so she stopped attending prenatal care. Right. So like this is like, I mean, like, I don't think I have to say more than that. Right. That's really sort of a compelling case of like how it can really be a huge, huge barrier for care at a time when it's really imperative for patients to be connected to treatment. Um, and then, yeah, then this other quote, similarly, we had a patient who delivered her baby without any prenatal care whatsoever because she was afraid to come into the clinic and get treatment because she was afraid she was going to get reported to Child Protective Services and other state agencies. Right. And so again, this is really sort of the real downside of this. Um, and then again, not surprisingly, this having clinicians be mandated reporters, and how frequently certain laws and policies are forcing, right, clinicians to have to report to Child Protective Services, like in the in the former case of Massachusetts of, anybody on medication treatment has to get reported. That gets in your way of providing the appropriate clinical care and the evidence-based care. So it's hard for patients to be their providers as advocates when providers are the ones turning them in, so to speak, to an agency that could potentially destroy their family or jeopardize their family. It makes us more of an enemy than an advocate. And then you have to build trust with the patient. And then you bring up CPS and potential involvement. It sort of cracks that trust and breaks that trust. And then again, mandated reporting was perceived by clinicians to be unfair and deter substance use care. So kind of on the similar theme, it's hard because especially patients that are stable on MOUD, they're doing the right thing. Addiction is a disease, and I feel like a lot of times we're still penalizing them for doing the right thing, which is again, I think a theme that you've heard me say over and over again. And I think that they are and this was sort of interesting coming in perspective, right? How this is particularly an issue for uh, pregnant and individuals, right? Because men who are who have substance use or are not, they're not addressing this issue at large because they don't necessarily come into care, right? So it feels like pregnant individuals are getting targeted because they're coming to care, and then this idea of seeking care then puts them at risk of then being reported. So again, talking about how this then becomes a barrier, and then other clinicians reported how lack of specificity in the mandated reporting statutes and child protective policy statements, as well as how their individual hospitals or clinics implemented these policies, are a big, big barrier. So there's a lot of confusion about what reporting requirements actually are. There's also confusion because there's a lot of variability in the way that they're implemented. So there might be the statute at the state level that says one thing, but then also kind of how it gets implemented on a clinic or hospital level is very different as well. And even just individuals' interpretation. So from clinic to clinic, there's variation, and then there's within the hospital team. So it really is this lack of consistency. And then there's again, one of the clinicians that reported how it's a huge challenge to try to give patients expectations about what's going to happen and how things are going to go, because there's so much variability in terms of how things are implemented, and also even variability in terms of the caseworkers that someone might end up getting connected with as part of this. So there's a lack of how cases are handled, as well as the communication and implementation. Okay, so the last theme that came out of this was how these mandated reporting policies were perceived to discriminate against individuals with opiate use disorder, and particularly those that have been historically marginalized. So I'll just, for the interest of time, I think there is a higher risk of targeting patients who are underrepresented, sort of like the whole DI perspective, looking at patients who are much more marginalized. They're more likely to be stereotyped and evaluated and reported. And we know we did this separate from the study, kind of had a colleague of mine had looked at the urine toxicology for infants at delivery for newborns, and that there was very much so in terms of disparity in terms of which moms and which infants were getting screened versus, so it was tended to be more likely that if it was a Black newborn was more likely to get tested than a white newborn. And our hospital finally implemented objective policies around when to use, right? But you're very limited in terms of having a significant clinical value. First of all, like, we reduced the number of screenings by like a lot. I think it went from the average of 3% to like less than 0.5% of infants. And then also it kind of leveled the disparity between you know, race and ethnicity. So again, really, really important to keep this in mind. And again, that, it also depends on socioeconomic status, right? So some private patients weren't getting reported because nobody would say anything, but if you were testing clinic patients, right, in the FQHCs or things like that, then there was more bias and more reporting. So again, another important piece to this. And so just to summarize and then be able to open up to questions, again, from the patient perspectives, not surprisingly, experienced a lot of stigma, discrimination, and felt punished because they had an opiate use disorder. And they experienced significant fear rooted in the stigma and discrimination they experience, and concern over losing custody of their children. And then for some of them could be really traumatizing. And like we saw the extreme of like even considering terminating so they wouldn't have to deal with this. And then the fear and stigmatization influences individuals' decision making, treatment decisions, well-being, and health experiences. And for the clinicians, it's mostly that how substance use reporting requirements and the potential for child protective services involvement are perceived to have minimal positive effects on the perinatal individuals and really negatively impact patients and their obstetric care and being a barrier for treatment. And the inconsistency in how these reporting mandates are applied and how cases are handled by child protective services present really big challenges and really get in the way of their patient provider interactions and trust, and leads to a lot of uncertainty and anxiety for patients. So with that, I will open it up for questions. And here's my email. Can reach out anytime. And I'm going to stop sharing. And hopefully I am doing okay on time.
Thank you so much. That was wonderful. It's so great to see qualitative data. Personally, I'm a little biased. And being able to integrate that into a large trial is just, I think, a wonderful thing to see too. So to open up to our questions, please feel free to put your questions in the chat. I'll also give an opportunity in a little bit to unmute yourself if you're interested. One question that we've gotten so far in the chat is, I'm glad you touched on the intersection of racism and stigma related to opioid use disorder. Did this come up in any of the interviews that you presented? You presented mainly patient and clinician interviews, I believe, in your presentation. So did anyone touch on that in the interviews?
They did, and I don't know that I put that much in there, but I think that was definitely one of the things that we identified as a theme, particularly even it's interesting because we had a diverse for the patient, we had a diverse group. We had I think out of the 17 participants that we'd interviewed, 10 identified as white, 3 as Black, and then we had 4 that identified as Latina. So we did have more diversity because for the clinicians, it was predominantly out of the 12, 10 identified as white. So but it came much more as a theme, interestingly, from the clinician perspective about how they were noticing how these things were absolutely, and I think that's one of the last slides I mentioned, sort of like the reporting was different depending on the participant's background and racial and ethnic identity. So I think that definitely did come up for sure, but surprisingly much more so from the clinician perspective than the participant perspective.
Mhm. Any other questions that people have?
Yeah, this is Andre. So thank you so much. It's just, we know these stories and seeing it to have, again, those important data to provide voice, and to give opportunities of voice for this. So I was just wondering, now that you have this, right? Where are you going with it? Like I'm so impressed with what Massachusetts has done. Like, how can we, leverage these data to educate, to help make change? So any sort of pearls of wisdom you have around that, if you want to talk a little bit more about how these data are going to be used in the future, anything like that would be great.
Yeah, absolutely. So that's precisely, so our we were just finishing up writing up the patient perspective, and our next paper is going to be sort of recommendations around this, right? And kind of how to be able to advocate. And obviously there's a fine line because PCORI does not necessarily allow us to sort of use this as policy advocacy. I mean, for policy recommendations, but we can use it for advocacy. So with that in mind, we definitely plan on writing a paper with these, kind of synthesizing these findings and really making clear recommendations, and some of them which I sort of discussed along the way. But I think, like you said, it's really, really poignant. The quotes, right? Like, I think there's something about, because this again, when at the end of the day, this all resonates with what we know from the literature, right? But to have the patient and clinician perspective and those voices, I think is very powerful. And so again, being able to bring it and maybe help some of this data to support changes like the one in Massachusetts, right? To sort of like go to the state legislatures and say, this is doing these patients are just these patients, these individuals are disservice. This is how you can implement potentially treatment, or think about treatment in a way that is going to help get patients care, and begin to sort of move away from really the like it's just the punitive nature of how a lot of these policies are implemented. And I think having these quotes can really bring that hope home, hopefully.
And
But yeah,
you know,
and trying to talk about it anywhere and everywhere I can is one of the things that I've been doing, and trying to partner with folks that yeah, that
and
can.
just thinking about, like, you know, when these data are published, well, because you are funded by PCORI, well, you all might be restricted from saying things. This might be a great opportunity for a set of commentaries.
Right.
So I hope you're thinking about, you know, the commentaries that could go along from people that are also doing this work and WAG and, you know, so just a food for thought. Thank you.
No, absolutely. No, this is why I was so happy to be able to come share this with you all, right? Because I know sort of this is we can kind of help build connections in any way that we can collaborate it and kind of get this out there. Happy to do that as well. Yeah, and I did as part of PCORI actually does this, where I got to go 2 summers ago to DC and actually talk to lawmakers about this project, and actually happened to have one of our participants who was brave enough to want to come down to DC with us to speak to Congress about this and share her story, and how like she had struggled, through prior pregnancies with opiate use disorder, and how it was really like engaging in a provider that was part of the study that really made a difference. And now she, was having her second child, and, had bought a home and gotten married, and, like the success story, with struggle along the way. And it was really, really powerful. And as part of that, one of the things I got a chance to talk to some of the staff members for one of the congresswomen with, the idea of like that we were doing this research, and she's like, okay, when it comes out, let me know, because this is important. We need to get this out there. We need people to be able to hear this perspective. So that's the other piece. We're going to be sending them out to them. Yes, go ahead, Jacqueline.
Hi, how are you? I'm Jackie. I'm an MFM in Wisconsin. I just love this paper. It's so hard to find great qualitative work to like share with people, and I feel like nothing really changes my hospital system's mind like this. But when I'm also, my other hat that I wear is the chair of the maternal mortality review for my state. And one thing we see over and over again, because overdose is now our leading cause of death, and we talk about basically every meeting, is not only the impact of reporting, but of child separation. It seems like you can like watch the train coming into the station the whole pregnancy, and it seems like sort of the final thing is, and then they were separated, and then there was an overdose event. And I'm just curious if you have enough follow-up from any of this group that have like experienced child separation, or if that's something on the horizon, because that's something we talk a lot about and we're really interested in, is how do we support people through that? First of all, how do we prevent it from happening, which is, I think, the essence of what we're trying to do here. But also if you have any follow-up information on that, because that's something we see every single meeting.
Yeah, absolutely. That's such a good point. And, it's one of the things I've been thinking about a lot. I also sit on our maternal mortality review committee, and in Connecticut as well, mental health and substance use disorders are the leading cause of mortality in Connecticut. And frequently what we see is, right, this is happening because there was, like one of the most recent cases we saw, it was precisely so someone who had child protective services involved. They had just been notified that they were going to have child removal, and she overdosed, right? And so I really like that. And this, I think, to me also really brings it home. And the other piece, right, if you think about not just, and this is true in Connecticut, but also nationally, is that a lot of these deaths occur late in the postpartum period, right? Frequently when a final decision about custody occurs, right? Because there might be the initial removal, or there's an investigation, and there's like this limbo. But then once, like usually right around like 6 months postpartum or later, is when these decisions about like final removal or not are occurring. And that's, I think there's something there, right? Because I mean, it's also that there's less engagement and less support, right? Because that's the other thing. How can we continue to have support for the first 12 months postpartum, right? And like, can we capitalize on a lot of changes in some states around Medicaid kind of supporting patients for the first 12 months postpartum and be able to continue care? Because I think that's going to be important, because those are important touch points. And you're not just like, oh, you had all this attention while you were pregnant, and suddenly like you got nothing. And it's when you're really struggling. So that's one piece. But I do think that there's something about how some of this child protective services decisions are happening later that might coincide. Unfortunately, to directly answer your question, we don't have any subsequent follow-up interviews, but it's something for us to think about for sure. Luckily, there weren't that many cases of child protective services removing a child. There was involvement. Of course, all of our participants in Massachusetts at the time had to have involvement with child protective services. Luckily, the majority, were just, the cases were close and nothing else resulted from that. A really, really good question. And I think to me, that's like the next place, like the next area I want to explore. How do we support these patients and these individuals, these women at that really critical time in the late postpartum period?
We had a question in the chat kind of bringing all this back to CAPTA.
Mhm.
So I was wondering if you wouldn't mind kind of taking that on. So the question is kind of about, in reading CAPTA, it doesn't really make sense why people are getting reported for or prescribed medication like methadone or buprenorphine. So I was just, if you could touch on kind of how your study findings can be interpreted in the context of the current way that CAPTA is written.
Yeah, and I think that's precisely the issue that I had discussed with the that staff member from the congressperson that I spoke to, was precisely this issue, right? It's the way that CAPTA and modification, I guess it was a 2016 or 2019 one, that really changed and added that required having a registry for states, and it was left vague. And in some states, what they interpreted is, oh, it'll be a mandated Child Protective Services report. And so I've been thinking a lot about this, because so Connecticut, I think it did it in the right spirit. So what Connecticut set up was a separate anonymous registry that anybody that had exposure, right, in utero would, have an automatic anonymous report at the time of delivery, right? That didn't include any information related to the patient or anything like that. And it was not connected in any way to Child Protective Services. The problem, again, is how these things get interpreted and implemented at the hospital system level, right? So that's the issue, is that frequently what would happen is that they'd make that anonymous referral, but then there'd be like, for some other, just in some hospitals, the policy is like, well, if you're making that referral, you should also, if you're doing the registry anonymous, you should also just make a referral just to be on the safe side, right? So like a lot of this very unnecessary sort of like hyper vigilant protective stance that hospitals take, right? Due to liability, because they don't want to have a bad outcome, that suddenly the practice was, even though in Connecticut it was separated, they somehow ended up combining it. So I think what's really important, I think having it, if we need to continue to have this registries, right, making them anonymous, but also really being explicit about separating them from Child Protective Services, that they're not the same, that keeping them anonymous, keeping them separate. If it really is that we need them. So I also then bring the questions like, well, are they really necessary, and what are they serving? Right? Because I think in the end, the downside to how this has been implemented and the impact on clinical care is worse, right? And it's actually having a negative effect. It's as you saw from the quotes, it's leading pregnant individuals to not want to seek care, to not seek evidence-based treatment, right? And it's creating a lot of the stress. And I think all of that is going to have worse outcomes, right? And I think that's really one of the main concerns that came out of when we heard the perspectives of the obstetricians is, well, they're not getting the prenatal care they need. And, that's going to just be worse for many, many things, because they're at higher risk anyway, and they're not getting prenatal care, et cetera. So I think there is really a big opportunity to advocate, to rethink the wording of CAPTA and this requirement, is it even really necessary? And then and until we can get a point where we can change that, can then we advocate at the state level that we can separate them so that it could be an anonymous registry that is disconnected completely from Child Protective Services. Yeah, and again, I think what's difficult about specifically answering the question in the chat is that each state has decided to implement this differently, right? And so it's my advice to folks is learn and get familiar with what the policy and the statutes are in your state, and then you can begin to advocate. And then you can advocate just locally. You don't even have to necessarily go to your legislature. Just advocate for your hospital to be like, okay, this is what the statute is. Why are we doing something that's not required? Right? Why are we putting this additional burden on these patients when they need is care and support?
Kelly, would you like to ask your question?
Yeah. Hi, good morning. I'm Kelly Butler. I'm a family doc in SoCal, and this is the center of all of my QI work in OB fellowship. So yay. What I'm running into in my hospital is this belief of like, but then how will we know, right? Especially from our social work team, we've gotten the feedback of like, quote unquote, what if we need to build a case? I'm wondering if you've had a response about more adequate ways to screen. And yeah, what are folks using?
Yeah, no, I think that's such a good point. And I think even that idea, I would just start challenging that. Like, how do we build a case? Like, why do you need to build a case? Right? Why are we going into it? Why are we going into this conversation or this patient interaction with that stance of we have to build a case instead of how do we support this patient? Right? How do we help this patient have a good pregnancy, a good outcome, and the supports they need to be successfully parenting this, of their infant, right? So I think I would just start there and then just bring it back to them. So like, why is it that we need to like, let's take a step back. Like, why is that our stance? Can we rethink that? So part of your question about, how do we know? It's like, well, again, it goes back to like, why do we need to know, right? What is it that's important at this point, right? So again, it is important for you as a clinician caring for this pregnant individual to know, but right, because that can help you support them and provide care. And I think that should be sort of where you're coming from and how you're approaching this. And then the recommendation, as you well know, is it's validated universal screening. So something that's happening for every patient that's coming into treatment, everyone, right? Regardless of, whether they're private pay, whether they come from a private practice or not, independent of their race, ethnicity, et cetera. So, and I think that we here, my colleagues at Yale had done a study a while back looking at what's the best tool. And honestly, even the tools that designed for screening and pregnancy are just as good as the NIDA quick screen, also known as the TAPS. And they have it's actually pretty straightforward. It's really plain language. It just asks about like very like, do you use substances, and then kind of does an assessment. There's an online version of it, and what's actually really nice about it is that actually will give you some risk stratification that can help you think about like, how do you support the patient. So that is one good tool, and that was actually one of the tools that we compared along with the 4Ps and the SERP and there was the Wayne State one as well, and I think the CRAFT, we compared all those, and in the end there was none that was superior. And I think for ease of use, the TAPS can be very good, but again, it has to be done universally for all patients. And again, from a clinical perspective, it's really building that alliance that's really important. And so, screening, and maybe it's negative, but maybe like just leaving that door open for the future. Because again, what you want to do is you don't need a urine toxicology test to tell you whether they're using or not. You really don't. You need to be able to build that rapport. You need to be able to build that trust so then they can disclose, and then you can work with them. So like, again, disclosure is going to be more important. And, like I mentioned earlier, that I have, I run our access program here, and I had got a call from an obstetrician who said, you know, we had this patient who was using cannabis, and she had disclosed the cannabis use, and we did a urine toxicology, and immediately I'm like, oh, but why, right? And then she's like, and it happened to be positive for cocaine, and I was like, okay, so you know, it did. So then, like, what did you do next? And it's like, well, so she essentially was calling. It's like, well, now what do I do, right? And I was like, well, nothing. You continue to work with her and kind of meet her where she is and ask her like what like, you know, what's going on, what type of support does she need, like, and what are her plans, right, in terms of what she wants to do, you know. Again, instead of freaking out and thinking like you're going to have to, like, in Connecticut there's no mandated reporting for substance use in pregnancy, but like a lot of times this flags folks for you know, a referral after delivery, and it's like, you don't have to go down that route. You really need to then just use this as an opportunity to have a conversation of how can I help you, and what is it that you want to do about, you know, your cannabis use, and what is it that you want to do about your cocaine use, and having that, you know, informed discussion about like the concerns she might have from a medical standpoint about cocaine use in pregnancy or cannabis use in pregnancy, right, as a conversation started. And she's like, well, what if she doesn't want to do anything, or what if she comes back and she still uses? And I was like, that's okay. The fact that she comes back is a win, and you want to take a harm reduction perspective, and you can say, okay, what's your goal? Okay, you're not ready to quit altogether. Can you cut down? And right, and just really the importance of continuing to build that alliance and meeting the patient where they are, so they continue to engage. Because eventually, right, like I said, 99, I think I've had only one patient that, like, I think had so many other trauma and other things she was dealing with, and she was so stuck in her substance use that, like, didn't have at that point like wanting to do the best thing for the pregnancy, and she just couldn't see herself stopping. But every other patient's like, I want to do what's right for this baby, for this pregnancy, right? That's really where everyone's coming from. They don't know how, and they need your help to do that. So I don't know if I answered your question, but as you can see, I get very passionate about this stuff.
I think
Don't we all?
Yeah, don't we all? I was just about to say the same thing. Well, this was wonderful. Thank you so much, Dr. Forray, for presenting to us today. You've gotten lots of praise in the chat, in addition to the questions that we just fielded. This was an excellent presentation, and I just want to emphasize, you know, some of the chat comments that have just been really happy to just see the voices of the people being impacted by these policies and regulations, and just kind of how systems and structures work, and just elevating their voices, especially in the advocacy space that you had the opportunity to do with someone with lived experience, which is so great to hear. So thank you again on behalf of WAG. So
thank you all, and thank you for all the work you do and for bringing this group together.
Yeah. So our next WAG Journal Club, just for everyone, just to remind you, will be Monday, February 10th at 3 p.m. Eastern Standard Time with Dr. Smid, and we look forward to seeing you guys there. Thank you again.
Thanks, y'all. Bye, Caitlin. Great work today. Thank you, Dr. Forray. Bye-bye.
Bye.